The master's hand holds the tiny little baby.
All right, thank you so much for the introductions. And so I am Dr. Amy Sosa. I'm a licensed psychologist. I practice at Mercy Health and then also have a private practice in Lake Geneva. Eating disorders are near and dear to my heart, which is why when I relocated here, I found the Dorn family, and they have just been amazing in networking me with the community here. So I really want to thank Project Maria and all of the volunteers for hosting this event today. So in the spirit of vulnerability, so I'm not one to sit and just lecture. I encourage involvement in practicing vulnerability. So if you feel comfortable and want to move forward a little bit, just so it's a little bit more interactive, let me know. And I'll start out by asking if there's anything in particular you want to get from this topic. So the topic today that I've chosen to address is teens and eating disorders. So really exploring the relationship between food and body image, and then how that works within the family system. So we all know that eating disorder recovery does not happen in isolation. It takes a village, right? So an entire family, community, network, treatment team. And so it's important to address the full picture. So I hope to kind of touch on some points today and also give parents some tips in terms of what they can keep an eye out for, as well as what they can do to foster an environment of intuitive eating and health at every size within their households. So is there anything in particular, just opening it up to the audience, is there anything in particular you would like me to address or that you would like to know from this presentation? All right, we can go to the next slide. All right, so this is the outline. So I'm going to do an icebreaker. So in terms of learning, again, I'm not one to lecture. I'm one to really participate and be with the audience and hopefully have you walk away with something important today. So we're going to do an icebreaker to further reflect on our own relationship with our own bodies and food. Then I'm going to give you some statistics on eating disorders among adolescents. We're going to look at some studies regarding fat bias in children and some of the implications of that. And then we'll look at what parents can do. So we'll look up some more research findings, and then I'm going to present and talk more about what parents can do. And then to wrap up, we'll revisit the icebreaker and see, it's almost like a litmus test, seeing where you were when you started this presentation and where you are now. All right, next slide. Okay, so instead of paper, I thought it would be best just to reflect on yourselves. So what I want you to think about is, and first I want you to invite the word fat into your heads. So just think about the word fat. And I want you to think about the words that you associate with fat. So I'll give you a couple moments to think about the words, characteristics, what you would use or how you would describe personality traits, lifestyle choices when you think of the word fat. Okay. And then conversely, I want you to invite the word thin into your heads. And then I want you to meditate or think about lifestyle, personality, traits, characteristics when you think of the word thin. Okay? So just kind of keep an eye on that as we go through this presentation. Next, what I want you to do is think about food rules you follow. So if you put a moral value to food, so if there are good foods, bad foods, healthy foods, unhealthy foods. So think about how you navigate your day in terms of your relationship with food and good and bad foods. All right, so we're just going to keep a pulse on that as we go through this presentation. All right, next slide, please. Okay, so this just outlines the importance of knowing about eating disorders. So early detection or prevention is best, and then early detection, and then tertiary interventions. Eating disorders, even though these statistics look really low, in the United States alone, 30 million people are afflicted with an eating disorder. So anorexia nervosa is 0.3%, which seems low, but then when you put it in the context of 30 million people, it's a pervasive problem that has psychological and medical complications and implications that really warrant treatment. Bulimia nervosa is 0.9% of the population. Binge eating disorder is 1.6. Binge eating disorder is a newer diagnosis within the Diagnostic and Statistical Manual that came out in 2012. And so this prevalence, this is newer research, and the numbers are actually even higher, so 2% and higher for binge eating disorder. Binge eating disorder is more than 3 times more common than anorexia and bulimia combined. And 40% of individuals with binge eating disorder are male. So eating disorders do not discriminate. They don't discriminate against race, socioeconomic status, gender. So it's important to become aware of all of the ways that eating disorders can affect your entire community. There are also what's called like a sub-threshold of anorexia. So those are like if you're following clean eating, if you can't eat certain things all the times, where there's a fixation on health that actually becomes unhealthy. And so that statistic is 0.8% of the population. Binge eating disorder is higher. And then this is why we're talking in it. Today's presentation is talking amongst teens, because the age of onset is 12 to 13 years old. And so in terms of our teenagers, they are definitely at risk, and it's important to provide protective factors to hopefully prevent an eating disorder from happening. All right, next slide, please. Okay. So I'm going to look through just in terms of households and what we can do to help prevent eating disorders. Sorry, I'm going to change this. Eating disorders among adolescents are often associated with functional impairment, and so that's when oftentimes they don't want to go to school. People go on hunger strikes, so there are lots of different ways. They isolate socially, start to wear lots of layers, don't want to eat lunch with others. Their grades start dropping because of malnourishment, and it's difficult to pay attention. So there are a lot of functional impairments associated with teenagers with eating disorders. Also, medical complications, death, and suicidality. So people with eating disorders are 40% more likely to attempt suicide. So that is, a very scary statistic that, again, warrants very serious intervention. So again, this kind of goes with a significant impairment that most teenagers, so up to 97%, reported significant impairment in many aspects of their life. And then, in particular, bulimia nervosa was associated with suicide plans, and bulimia nervosa and binge eating disorder were associated with suicide attempts. All right, next slide, please. All right. Okay, so this is also important because sometimes this happens, and then people say, like, they didn't learn this in my house. Where are they learning this? Kids obviously are infiltrated with information, right? So from their family, from their communities, from their schools, from the society in which we live. And so kids as young as 6 years old show that they show fat stigma or fat prejudice, to the point where, if you look at this one study, young girls and boys describe silhouettes as overweight children as being lazy, dirty, stupid, ugly, cheaters, and liars. So if we go back to the icebreaker that we did today, if I actually surveyed the room, most people would have similar descriptors in their minds when they think of fat, and similar descriptors when they think of thin, because this is pervasive within our society, and that's why events like these, we all have to come together to change the language and change the dialogue in terms of how we think about eating disorders. So again, 6-year-olds were shown drawings of normal weight children, an overweight child, and children with various disabilities. And then all children rated the overweight child as the least likable. Children are bullied for weight issues, or not weight issues, but if they're quote unquote overweight. So there's a lot of fear, and again, fat stigma and fat shaming along with that. 30 to 70% of individuals seeking treatment for an eating disorder were provided weight loss treatment. So this statistic is alarming, and I know that's a huge range, 30 to 70%. I would say it's closer to 70%, and in the work I do, I often then have to kind of undo a lot of the learning that well-intentioned medical providers were giving in terms of weight loss. So what I say with eating disorders, when someone comes in and their focus is weight loss, it's almost like someone with depression who's sleeping 15 hours a day. That's like prescribing them to sleep longer, right? And so it's really prescribing the symptom, and it has significant adverse effects that perpetuates the eating disorder for much longer. So it's actually maltreatment in terms of treating the person holistically with their eating disorder. All right, next slide. Okay, so then in this study, he looked at binge eating. So he looked at adult onset binge eating versus child onset binging. And he looked at 18 years old was the cutoff if you're a child or an adult. So 30% endorsed child onset binge eating. And then of the children who endorse binge eating, after a binge, they reported significantly less anxiety than their adult counterparts. So it shows when kids start binge eating, and we'll talk about what some of the triggers are to binge eating, because there are many, from an early age, they're more likely to use that skill as a coping strategy because it's adaptive and it helps them decrease their anxiety. All right, and then we can kind of go through the rest. You guys can read the rest of it, but we'll go to the next slide. Okay. Again, looking at the age of binging versus the age of dieting, those who began binging before dieting began to binge earlier, so ages 11 to 13. And they also had more exposure to negative comments about their body and have an increased risk for depression. So this is where, again, if you think about the good, bad foods and then some of the weight stigma, if you have a child in a larger body and then some of the messages that that child receives, then they may be more likely to eat in secret and binge eat the foods that are either adults say are forbidden for that child or that they don't allow themselves to have. All right, next slide. Okay. And then again, this looks more at secretive eating and overeating as risk factors for binge eating disorder. So this was a really interesting study because it looked at children ages 0 to 5 years old. So it was a longitudinal study over 5 years. And they looked at 18.1% of kids ate secretively and 33.8% of those children overate, and that they peaked. So the eating disorder behaviors actually progressed with each year that they aged. So what they found, because then they wanted to know, why are these kids restricting, or why are these kids overeating? Why are they eating in secret? And it was actually when parents restrict enjoyable foods that cause them to eat these foods more. So something I often say with my clients when there are certain foods that are forbidden, or, oh, I don't buy those foods in the house, then I'll look at my, teenage client and say, what do you eat at friends' houses? And they often eat the foods that were forbidden at their own house. And so we talk about incorporating those foods because all foods are okay, and it's important to send that message to not perpetuate these symptoms. And from the earlier studies, you guys have seen that when the risk for binge eating disorder early on, or binge eating early on, actually sets the stage for bulimia, depression, and other eating disorder diagnoses later in life. They also showed other factors that contributed to this. So which is interesting because they looked at maternal and paternal eating inhibition, so like dysregulation around food, and mothers were more influential in that. Higher maternal body dissatisfaction, so when you're putting yourself down in front of your children, even if you don't mean to, but some of those messages that you might not even be aware of, those kids pick up on, all of those are correlated with secretive eating in children. And then maternal dietary restraints, so restraining what you eat, being on diets, as well as a higher drive for thinness, are associated with more overeating in children because, again, it's that vicious cycle between I can't eat this, I'm going to eat this in secret, and then when I have it available, then I overeat it. All right, next slide, please. All right. This is also interesting because when we think about intuitive eating, so if you guys have ever been around little kids and you put their favorite food in front of them, they eat when they're hungry and they stop when they're full, and they'll just push it away, even if it's their favorite food. So we all have that innate capacity within us. We lose it over time due to social cues, due to messages about dieting, due to many different reasons. So when kids are actually pressured to eat all the food on their plate, it's actually associated with some emotional disinhibition. Because when you think about it, emotional states are physiological states. So kids have to be connected or attuned to their bodies in order to understand or know what they're feeling emotionally. Same thing with eating. And when we start to sever that connection between mind and body with food, that translates to severing that connection emotionally. So then they're actually more emotionally dysregulated. Again, kids' perceptions of if their parents are restricting snacks, so they limit the access to snacks, that was also associated with dysregulation when enjoyable foods were available. And then again, same thing, that when parents report that they restrict girls' access to enjoyable foods, that was associated with an increased consumption of that food after a full meal. So when they're full, then they tend to eat more if that's a forbidden food. All right, next slide, please. Okay. I also thought this was interesting. Then we'll get to what you guys can all do as parents. Children of parents who use food as a reward were more likely to eat when stressed, because when kids are super excited and then they use food as a reward or as a treat, quote unquote, then they learn to regulate those really exciting feelings with food. And then when they're distressed, so those intense feelings one way or the other, they're more likely to use those foods use that as a coping skill. So use food as a coping skill. So what we talk about in eating disorder treatment is neutralizing food, that all food is okay. So it's just sort of eating and moving on with life, appreciating food, seeing food as nourishment, but not putting it on this pedestal, because then again, that causes that emotional dysregulation. All right, next slide, please. So what can parents do? So parents can model intuitive eating. So again, it's eating when you're hungry, stopping when you're full, and eating to satiety. It's not a perfect art. So the best thing you can do is model flexibility. So allowing all foods to be okay. At times, I'm really full. I'm gonna rest or take a break. Same thing with just in terms of instead of, you have to finish your plate in order to have dessert, making dessert okay, because when you make dessert okay, kids aren't always going to want or crave dessert. Again, neutralizing food, so there's no moral value to food. Oftentimes when people feel guilty after eating a cookie, it's like, did you kill someone? What happened? Or they went to the grocery store, and if someone says, I did bad at the grocery store, I'm like, did you steal? What happened at the grocery store? And so it's really just looking at how much power those thoughts have in our minds and neutralizing food, again, so we can just see it as nourishment again. Celebrate differences. So this is a big one just in terms of body image. So celebrate all bodies. We have a lovely display of celebrating all bodies out there, that all bodies are okay. Watch the language that you use in your house just in terms of how you talk about yourself and the bodies of others. Next slide, because we'll talk about what else. Get rid of the scale. So when you model weighing yourself, then it's sort of weighing yourself as worth. And in terms of health at every size, weight is not a parameter of health. There are many other indicators of health. So when someone says, I want to be healthy, so I'm going to lose weight, I often ask, how are your labs? How are your vitals? Oh, they're fine. And so how are you measuring health? And so when you really look at this, metal or plastic device, and how much, the device is really just measuring your relationship to gravity, how much power that has over people's lives when they weigh themselves daily, weekly, even monthly. So just getting rid of the scale, because then that allows you to trust your body and trust what your body's going to do. Comment on qualities, traits, or achievements instead of focusing on, you look so good. Wow, you're so strong. Wow, you did a great job at that. So just more commenting on qualities of people instead of how they look. Model positive self-talk. So at my table, there are thank you cards where you can actually write a thank you card to yourself, because oftentimes we care a lot and focus a lot on other people and not so much ourselves. And so it's important to model taking care of yourself and liking yourself, and model confidence. Confidence is okay. And when kiddos and teenagers see that confidence, then they can stand taller, they can stand prouder, and then that's going to set them up for life. So movement is a big thing. Oftentimes people say exercise. So I have to exercise to lose weight. I have to exercise to burn calories. Or I have to eat a low-calorie meal. So again, food is fuel and exercise is, or movement is enjoyment. And so move because you want to, not because you have to, or because someone is telling you to, or because you ate something. So when you model like, today I'm tired, today, I'm just gonna sit back and relax, or today, guess what, the weather's really nice, I'm feeling really good, I wanna go out for a bike ride. When you practice that flexibility with food and you practice that flexibility with movement, then again, that empowers teenagers, so kids and teens, to start to make decisions for themselves, and then that also translates to other relationships in their life, where then they can be more confident, they can be more assertive, they can take care of themselves in a better way. So, and then next slide. All right, so revisiting the icebreaker, and not that you necessarily has to shift, but again, the icebreaker was a way to really take inventory of, where am I in my own relationship with my body? Where am I with these biases I have with fat and thin? So looking at how to shift your perspective in that way. And then think about a commitment. So I'm always, thinking about intentions and intentional living, and just setting an intention today of like, what can I do to either take care of myself, to, start to shift some of the culture in my family around food, to stand up for myself or speak when I hear something, just setting some sort of intention of something you can do today to help kind of carry this forward. So any questions, thoughts, impressions, anything that kind of struck you guys? No? All right. Thank you all. Enjoy the rest of your time. Thank you.